A 62-year-old Caucasian woman was first diagnosed with chronic lymphocytic leukemia of the B cell lineage, BCLL, in July 2002. She showed marked leukocytosis with a white blood cell WBC count of 43.35 times 109 per liter, 82% lymphocytosis, accompanied by slight anemia, hemoglobin 11.1 grams per deciliter, and a platelet count of 129 times 109 per liter. Flow cytometric immunophenotyping of peripheral blood identified a CD5/CD19/CD20/CD29 positive clonal B lymphocyte population with capillary chain expression. A chromosomal fluorescence in situ hybridization FISH analysis revealed DEL14Q32. Upon this first presentation, the patient's general conditions were good. There was no peripheral lymphadenopathy or hepatosplenomegaly detectable. Hepatic and routine laboratory parameters were in the normal range. Plasma proteins, as detected by electrophoresis and immunofixation, were without pathological findings. Therefore, a watch-and-wait approach was chosen. Upon reevaluation in December 2002, a lymphocyte doubling time of less than 6 months was found. The patient had developed splenomegaly and cervical as well as axillary lymphoadenopathy. The patient received 5 courses of chlorambucil until May 2003, but did not show significant regression of tumor lesions. Leukocytosis and non-hemolytic anemia further deteriorated, accompanied by a 10% weight loss. Platelet counts remained normal at this time. Administration of packed red blood cell transfusions was necessary. Fludarabine monotherapy was started in June 2003 at a dosage of 25 milligrams per m2 day for 4 days. After the first cycle, the patient developed a fever, a secondary antibody deficiency, and a Coombs-positive severe anemia without detective hemolysis. In addition, protracted thrombocytopenia developed. The patient became transfusion dependent for erythrocytes and platelets. Upon immunoglobulin substitution, the therapy with chlorambucil was resumed. Under this regimen, the CLL progressed to Bennett stage C with subtotal bone marrow infiltration by mature lymphocytes with almost no residual hepatopoietic activity. Absolute granulocyte count 140 per microliter. Leukocyte count was high, 210 times 109 per liter. Bone marrow aspirations showed subtotal bone marrow infiltration with displacement of normal hematopoiesis. At this time, a combination therapy was started. After the first cycle, the thrombocytopenia did not improve, and the patient experienced a retinal bleeding. There was no response toward CLL-related symptoms. Considering the remaining therapeutic options and the risk of any further aggressive chemotherapy in a severe pancytopenic patient, Rituximab monotherapy was started with a weekly dose of 375 milligrams per m2. During this therapy of intensified Rituximab, the patient became transfusion-free. 12 weeks after the first dose of 600 milligrams per m2 Rituximab, anemia abated to a hemoglobin level of 9.2 grams per deciliter. Platelet count progressively rose from 136 times 109 per liter, and leukocyte count decreased to 5.08 times 109 per liter. This regimen was sustained 20 times until November 2005. During this therapy, the hematopoiesis recovered completely, and the hemoglobin level reaching 11.9 grams per deciliter. A white blood cell count of 4.38 times 109 per liter, and a platelet count of 1.38 times 109 per liter. Both the lymphadenopathy as well as the splenomegaly regressed completely. Over the entire term of the maintenance therapy, treatment of pulmonary infections by oral antibiotics became necessary 3 times, but could be performed at the outpatient level. Prognosis: chronic lymphocytic leukemia of the B cell lineage.